Randall Wolf here, Houston Methodist Hospital, DEBAKEY Heart and Vascular Institute. It must be the first Tuesday of the month. It is Tuesday, 5 p.m. First Tuesday of the month, 5 p.m. We have a discussion about atrial fibrillation. These have become very popular. Welcome to today's program. We've got a lot of things to discuss. I want to jump right into it, but I do want to inform you that you have an opportunity to also participate in this 1 hour program. You can join by text or you can join by the web. It's up on your screen now. If you'd like to join by text, simply take your phone, 37607, and in the box put DEBAKEY, and you can text in your message. It can be a comment. It can be a question for me, and we do try to get to every question during the hour. So it's never too early to get in the queue for questions. We usually get anywhere from 20 to 40 questions in an hour. Topic is atrial fibrillation. So if you have atrial fibrillation or one of your loved ones has AFib, you may get some valuable information. You may also ask the questions. If you would like to join us by the web, go to PollEV, that's POLLEV.com, enter DEBAKEY, and then you can respond and type in your question or comment. So you can join us by text, 37607, put in the text box DEBAKEY, DEBAKEY, or on the computer, PollEV.com, enter DEBAKEY. We get a lot of questions about what is different about what I am doing here at Houston Methodist. And I think it's basic to understand that this is a fundamentally different approach to the problem of AFib. AFib, I believe, along with many others, is a nerve problem. It's not a muscle problem. The heart is a muscle. The nerve endings are on the outside of the heart, not the inside of the heart. So it comes as no surprise then that therapies that mainly attack the inside of the heart, which is primarily catheter ablation with either burning or freezing, still has an AFib free rate that's less than one would hope for. And it's not uncommon for patients to require 2, 3, 4 ablations, still be on medicine, still be on blood thinners. But if we change this and understand that the AFib probably usually starts as a vagal AFib, and that this is a problem of the autonomic nervous system, and we know the nerves come in from the outside of the heart, then the treatment changes dramatically. By short history, over 20 years ago, this is where my research was focused, and we devised a device that would fit around the heart during open heart surgery and create a line and also block these nerves from the outside, and it would also make a line on the inside in about 12 seconds. Early on using that device, I felt we could also use it in patients who did not need open heart surgery, but patients who had lone AFib. That means they had AFib without coronary disease or valve disease and did not require any open heart procedure. Since 2001, I've been performing that procedure. We initially called it bilateral pulmonary vein isolation and closure of the left atrial appendage. One of my patients in Cincinnati, Ohio, who was a skydiving photographer, said, "Doc, that name is never going to fly." And George Rabe is the one who named it Wolf Mini Maze and started a website. That website is very active today. It's gone through several iterations. You can go to wolfminimaze.com and view that website. If you have AFib, you'd like to talk to me or get more information, there is a way to do that through the website. We do video consults every day. I did 14 of them today. We talk to patients all over the country who have AFib, maybe have not had an ablation, maybe had an ablation, maybe you're trying to decide what to do about your AFib. And the video virtual visits are very popular. You do not have to come to Houston, and I can look at your information and give you my opinion on what your options are for treatment of AFib. Doesn't obligate you to come to Houston, doesn't obligate you to a catheter ablation or surgery or anything. So this is used by a lot of people. wolfminimais.com. The other way to reach us directly is 713-441-9342. 713-441-9342. Now, if we can suggest to you that there's nothing wrong with your heart and AFib and that this is really an imbalance of the autonomic nervous system, then it makes sense that that's the area we should attack and not necessarily burn up the inside of the heart or freeze the inside of the heart. Once that occurs, that's irreversible. Whereas attacking the nerves on the outside, particularly the nerves around the pulmonary veins, we can get an even better outcome, that is without burning up the heart. I've got our big boss here today is producer Tyree Horn and also Obed. Mr. Producers, if you could bring up my slide now. I'm going to go to play on my slide. And we're going to look at a particular slide here. Vagal AFib. We're talking about the autonomic nerves around outside the heart. These are the nerves that make your hands sweat when you're on top of a tall building and you look over the edge. How many of you had that? Happens to me. And it happens in a second. Or these are the nerves that make your heart rate go fast when you're sitting at home watching a scary movie. Why should that happen? You're not running. You're relaxing at home. That's your autonomic nerves. And several of these vagal nerves are right around the pulmonary veins. But it's hard to get to the outside of the heart from the inside. It's easy to get to the outside of the heart from the outside. And that's what the mini maze does. I developed a scheme along with Sonny Jackman years ago of where these ganglionic plexi, which are essentially these vagal nerve endings, are around the pulmonary veins. We mapped it out, and today, including yesterday, I still map these areas and treat these areas. As far as I know, I'm the only one that still does that. I shouldn't say still, whoever did that, but that's the key in my mind, and that's how we get really good results. We treat the ganglionic plexi of the heart, particularly the ones that are around the left atrium. If I go to the next slide, this is a schematic, some pictures of what it looks like. Signals come from your brain and from your spinal cord from the autonomic nervous system, which is in two parts, sympathetic and parasympathetic. The parasympathetic is the vagus. That tends to slow your heart. The sympathetic tends to increase the heart rate. And these are mixed, and if you look at the, let's see if my pointer works here. It looks like it, not sure it does, but anyway, on the right side of the screen, you can see a schematic, a cartoon of the left atrium. And these are where these nerves are, but they're on the outside of the heart. You'll notice they're around the pulmonary veins. So being on the inside of the heart is close, but you're not close enough. You missed it by that much. But if you come from the outside of the heart, we can attack these ganglionic plexi. Yesterday, patient I was working on, continuously out of rhythm, heart rate 160, felt terrible. We did the nerves on the right, still out of rhythm. Did the nerves on the left, in rhythm. This is before we even did any ablation of the veins, just the nerves, back in rhythm, been in rhythm since. So there really is something going on here, and it's important. There is a paper that's pretty extensive that was published last year called Ganglionated Plexi Ablation for Treatment of Atrial Fibrillation. This is very important. This is a very long paper. It's a technical paper. It's in medical jargon. But if you really want to do some research, my point is there's a lot of information about autonomic nervous system and AFib. It's a nerve problem. It's not a heart muscle problem. Some of you may know that some time ago, I think my daughter was about 15, maybe 17, 18, I don't remember. She started a Facebook group called Wolf Mini Maze. And I don't think there was anybody on there for years. Then Sandy came along, and she became administrator of this site, and it's really taken off. And now, in part thanks to our good results, in part thanks to Sandra Schrameyer, a lot of people are joining this site because there's a lot of information and camaraderie about AFib on the site. Sandy has an interesting story. It's a story that a lot of people can relate to. So I've asked her to join us tonight for a couple of reasons. One, there's some areas that she knows that gets some of these questions and she can answer these. And also I wanted just to thank her personally for her involvement in working with this site, because she doesn't have to do this. She's a retired registered nurse. But she's very interested in helping other people who maybe have a similar story to hers, and she thinks maybe she can help them. And in fact, I'm sure she's helped a lot of people, probably more than I have. So Sandy, I want to thank you for joining us this evening. And maybe the best thing to do is I'm going to repeat again how people can join us and ask questions to me or you. And then two, you can give a little history of your own if you would like to, and then you can go into what some of the common questions that you get. So again, remember, if you'd like to ask a question, you can take your phone, go to 37607, and then in the text box put DEBAKEY, or if you're on your computer, go to POLLEV.com, enter DEBAKEY. You can ask Sandy or me a question, or you can make a comment. And we will try to get through all your questions this hour. Sandy, thanks for joining us this evening. And maybe we should start from the beginning and give a synopsis of what you went through with AFib as a person in the medical field.
Yeah, most everybody on the mini maze pretty much knows my story, but we have people joining all the time, every day. And for those who don't know my story, I had 3 failed ablations. I wish I'd have found Dr. Wolf before I went through 3 failed ablations, but I'm not one to put a Band-Aid on something. I want to cure it. And I agreed to the 3 failed ablations, and one after the other. The medications I couldn't tolerate. My body just did not tolerate those meds at all. And after the 3rd failed ablation, my EP told me the only other option for me was a AV node ablation and a pacemaker, and I refused that option. I know as a nurse that pacemakers should not be used to treat AFib. They're basically used only to treat very slow heart rates that are dangerous because people can pass out, or long pauses in heart rate for that very same reason. And having a pacemaker for AFib may help your symptoms a little bit because your heart is set at a prescribed rate at about 60 beats per minute. However, you still have AFib. You still need medications. You still need a blood thinner. And AFib can still be damaging your heart, as well as medications taking a toll on your body. So I refused that method. Walked out of the office, became my own patient care advocate at that point. 3 ablations too late, but regardless, I found you. I had the mini maze, and it's over 3 years now, and the rest is history. And I just know that people don't have to live this way. And it's just not known. The mini maze was not known out there. If I get one question repeatedly asked to me, it's why didn't my doctor, why didn't my EP say, recommend this, or why don't all the EPs in all the states and all the hospitals do this? And number one, they won't recommend it because they can't do it. An EP cannot do this. It is considered a surgery, and they won't recommend it because they'll lose a patient. But I just know that they don't have to live this way, and my goal was to get it out there and let other people find out for themselves how wonderful this is. Being on no medications, I take no blood thinner, have to not worry about a stroke. I just want to get the word out there.
Well, maybe you should add, since we're talking about your personal story, we also introduced you into the link. Maybe you should mention that too, because I think I'm probably one of the only people in the country who uses those routinely after a surgical procedure or even after ablation. You never had a link after your 3 ablations, did you?
I asked for one and I was refused. I asked for one.
So explain what a link is. Let's start out from the beginning so we don't lose anybody. Explain what a link is as a medical professional and as a layperson. In layperson terms, I guess would be better. And then explain what it does for you.
Okay. The link is just a little small monitor that's placed directly under the skin, just to the left of your breastbone. The old batteries last for 3 years. I understand the new batteries now last as long as 5 years.
Correct.
It gives you a 24/7 reading of what my heart rate does at all times. For me, it's just peace of mind, knowing, even though I know I'm not having AFib, because I knew the minute it entered my body and I knew the second it left. But you have a reading of that, and you can report to me that, hey, you're having nothing, you're doing great, and the whole bit. I did ask, after my 3rd ablation, I did have some relief from the AFib. The first 2 actually made it worse. It came back with a vengeance. I did have some relief, but I mean, how successful is it if you still have to take medications, you still have to take a blood thinner, you still have to worry about having a stroke? That wasn't good enough for me. I wanted it gone. And the link provides me that. Now mine is coming up probably, I'm over 3 years now, so I'm sure the battery's going to be wearing out soon. And I'm thinking of probably having it put in again, just for the peace of mind.
The link algorithm calculates the amount of AFib or atrial tachycardia per month as well. So each month I can explain to patients what % of time their heart's in rhythm. And fortunately for most of them, it's about 100%. We have some patients that have not been in rhythm for 5, 6, 7 years. For them to be in rhythm 99% of the time is pretty amazing. The other thing that I learned from experience, it took me a while to understand, is people would come back and say, Dr. Wolf, I haven't felt this well in 10 years. And I thought, well, that's crazy, because, okay, you're back in rhythm. You should feel a lot better, but better than you felt in 10 years? It took me a while to understand, but I think I understand it now. Half of it's getting back in rhythm, people. The other half is getting off the medications. Right. I mean, these are strong medications, and they make you feel lousy. And people would say, I'd get to noon and I was pooped out. I was done for the day. Now, because I'm in rhythm and I'm off all medications, I have a lot more energy. Well, yeah, you're not on the high-dose beta blockers or Sodalol. Also, a difference from other therapies is after the mini-maze, we do not require you to abstain completely from alcohol or coffee. So if you want a cup of coffee, you can have it again. If you want a glass of wine at dinner, you can have it. A lot of these other algorithms and therapies pound into your head that you'll never live a normal life, you can never have a drink of alcohol, you can never have a coffee again. That's just not where people want to go. So this therapy allows you to get back to your life. Now, Sandy, you take a lot of questions, and just off the top of your head, you can, well, wait a minute, I'll tell you what, before we do that, let's take a few questions from the audience. We're getting questions coming in now, and that's good because you have a couple experts here. I've been doing this procedure since we thought of it in 2001, and Sandy is a medical professional, an RN, and she has both experience in the medical profession as well as being a patient. So your questions can go to the text on the phone, DEBAKEY 37607. So you go 37607, type in DEBAKEY or pollev.com and then enter DEBAKEY. Question, if you are not in AFib at the time of surgery, can you accurately map the ganglionic plexi? Great question, very thoughtful. Easy answer, yes. It doesn't matter whether the heart's in rhythm or out of rhythm at the time of the procedure. In fact, it's a little bit easier for me to map it out of rhythm, but it doesn't matter. It's the same. And like the patient yesterday, we checked 9 levels on the right side. This patient was active at all 9 levels. After we did our isolation of the ganglionic plexi, we tested all 9 levels again. They were all negative. On the left side, we did the ligament of Marshall, divided it, boom, sinus rhythm. Second question, any conditions that would exclude consideration of Wolf mini-maze? The answer is yes. Some of them are absolute and some of them are relative, but the good news is most of the contraindications are relative. One is weight. It's more technically challenging to do a mini maze once the weight gets very high. Although the first patient yesterday was 5 feet 8 inches tall and weighs 320 pounds, so it's a pretty big patient. We were able to do it, but it is easier to do when the weight is a little better controlled. But we still do a lot of very overweight patients, and I am able to do that. Mitral valve procedures, to me, are a close to absolute contraindication. So if a patient has had open heart surgery or minimally invasive open heart surgery and has their mitral valve either repaired or replaced, that's a pretty strong contraindication because generally that surgery is done right in the area where we need to get around the ganglionic plexi and the pulmonary veins. And since surgery has been performed there, there's generally a tremendous amount of scar in that area, and it's difficult from a technical standpoint to do the mini maze procedure. What about other people that have had heart surgery? What if you've had bypass surgery? We have been successful in those cases. I've done about 40 of them now, I guess, in that situation. A pretty famous case was a retired colonel in the Air Force who came to me who'd had bypass surgery. He was in heart failure. He was told he might need a cardiac transplant, a heart transplant. He was being worked up for the heart transplant. He came to me and he said, "Doc, I feel I'm in heart failure because of my AFib. I went into the hospital with AFib. I ended up with 3 vessel bypass. I went out of the hospital with AFib. They never fixed my problem." His ejection fraction was very low, 15%. And I said to the colonel, I don't know, this is pretty low. We did the mini maze on him. It was a redo. He's had no AFib and he's been off medications. His ejection fraction came back up to over 50% and he's over 16 years out from his procedure. So that's another thing we should mention. So far, we now have many patients that are 16, 17 years out, still no recurrent AFib, and still no medications or blood thinners. If you have cancer, they say if you go 5 years cancer-free, you're cured. But you'll hear some doctors say, well, 17 years, he's still got AFib. I don't know about that. I think if you're out 5 years and you don't have AFib anymore, you're in pretty good shape. Well, this is not a question, it's for Sandy, but it says, no question. Just want to thank Sandy for all she does to help patients and future patients. While a few more questions are coming in, and please, this is the best time to ask your question. You've got both me and Sandy here on the line with you. So we'll flash that poll EV up there on the screen. In the meantime, Sandy, why don't you share with us some of the common questions or comments you get off the top of your head?
Well, talking about the meds, first of all, the meds were worse for me than the AFib. I literally couldn't function, not to mention the fact that I was extremely depressed on them. You were anxious from the AFib, and then the medications make you depressed, and it was just a vicious cycle. But I think what bothers me the most is a lot of people will say, well, my doctor told me that the mini-maze should be the very last result, or the very last thing that you should do.
Resort, and last procedure.
Resort.
Yeah.
Correct. And the thing is, I mean, why? Had I known, I wouldn't have gone through everything that I went through before having the mini-maze. And, I think the big question is, too, again, other than saying, well, my EP never mentioned it to me, they want to know why it's not being done in every state and every hospital, if this is the cure-all. I think the other thing that really, really bothers me is when people are begging, what do you take? I have arthritis really bad. I have another painful medical condition, and all they tell me I can take is Tylenol. This is the option for them, because with the left atrial appendage clamped, you no longer have to take a blood thinner. You can go back to your anti-inflammatories if you need to, and you never have to worry about a stroke again. Yeah. I mean, that was huge for me. I don't have a problem where I don't have arthritis or anything like that, but just the stroke issue was huge for me, to not have to worry every time I woke up wondering, is today the day I'm going to have a stroke?
Sandy, let's take a few more questions. I've had 2 ablations on the right side. Now I have AFib for about a year. This is very common. See a lot of patients that start out with atrial flutter, and there are 2 types of atrial flutter. There's typical atrial flutter, and there's atypical atrial flutter. Typical atrial flutter is on the right side of the heart. Atypical is on the left side. Atypical A flutter is almost always after a catheter ablation. There are whole conferences on what to do about A flutter after a catheter ablation, so it's quite common. The right side is usually just typical flutter, and the best procedure for typical flutter is a catheter ablation for typical. So this is a little bit confusing, but we're saying for AFib, consider something besides ablation. On the other hand, if you have typical right atrial flutter, an ablation is very appropriate. I never conceived the mini-maze to treat atrial flutter. It was to treat AFib. It turns out it treats atypical left atrial flutter as well. So you had 2 ablations, which is appropriate for right-sided flutter. But now, what very often happens, now you have AFib. Very good candidate for the mini-maze. You could be a candidate for a catheter ablation of the left side, or you could go for the mini-maze. Those are a couple options, or you could stay on medications. And I encourage you to go through the risks and benefits of those different options. And I think Russ made a very nice matrix on that. What should I do? Nothing, meds, catheter ablation, mini-maze. And I think is that available on the Facebook site? Or I think it's available on wolfminimaze.com. I don't know about the Facebook site.
I don't know. I do have a copy of it, though. We can probably upload it.
The matrix of what to do. But what I wish, and Sandy, you touched on this earlier with the EPs, but I just wish that most physicians would say, these are your options: medications, catheter ablation, and mini-maze. At least just mention it. You don't have to steer them towards it, but at least mention it to the patient so they can make their decision.
They should have an option, correct?
I have a neurostimulator for essential tremor sitting over the heart. It was not a problem with ablations. I turned it off. Could Dr. Wolf work with it? Yes, that's not a problem for what we do at all. In fact, it's even easier because everything that I use, these are bipolar instruments. That means there's no grounding pad on the body. The electricity only goes from here to here. That's one of the reasons why it's so safe. With a catheter ablation radiofrequency, you're getting electricity in your heart that has to somehow exit on your groin where there's a pad, a grounding pad. If that electricity takes the path of least resistance and goes through the esophagus, it can cause an esophageal problem, and those are 60% fatal. With the mini maze, with the procedures that I do, the electricity only goes from here to here. It's incredibly safe. I've had serious acid reflux since my second ablation. Could this be a vagal nerve issue? Very interesting. I got a whole slew of patients who said that after the mini maze, their stomach problem went away too. It's the vagus nerve. It's the same nerve, and very common. And in fact, if we go back to the 1960s, the most common operation in the United States was to cut out part of the stomach for ulcers, stomach ulcers. Then we found if we just cut the branches of the vagus nerve to the stomach, it stopped it. I think we're in the same sort of boat with AFib. Burn, burn, burn the heart. Cut out the stomach. It's not the answer. Treat the nerves. Then you don't have to burn the heart. You don't have to cut out the stomach. So I've had a lot of patients that said the stomach problems went away after the mini maze. Have you heard that, Sandy, at all? Or
I didn't have acid reflux, but I had a problem with bloating, and that did go away. It took a while, but that did go away. Yeah. You talked also too about a flutter. I had flutter after my ablations and had to be cardioverted, and I did have flutter as well after my mini maze for a while. But that went away totally. I know that the mini maze isn't meant to cure flutter, but it went away. I haven't had any flutter at all.
It will take care of left atrial flutter, because left atrial flutter are usually incomplete lines from the ablation. The best chance of not having any AFib anymore with the mini maze is if you haven't had ablations. However, generally we see what Sandy had was after the mini maze, if you've had prior ablations, the AFib goes away immediately. The flutter takes a little bit longer to go away, but it does. I'm from South Carolina. What would be my recovery time, and what would you do for follow-ups? We just had a patient from South Carolina here, I think last month. We see a lot of patients from that great state. The key is the link. In my mind, because we do virtual visits with patients from all over the country. After you go home to South Carolina, we do a virtual visit. I see you like we're talking today, but right next to me, because you have the link put in, I also see your EKG every day. You don't have to go to the doctor's office. You don't have to go to the emergency room. It's right there. So in a way, we almost have a better visit than if you came back to Houston for follow-up. So the follow-up I think's been good, but let's hear from a patient. Sandy, follow-up, because you live far away too. You can tell them where you live if you like to, but that's personal. That's up to you. But
I live in Wisconsin.
I mean, it's a hike from Houston. It's a hike.
Yeah, it is. It's a hike from Houston, but we stayed connected. You were there when I needed you, and
what do you think about the follow-up using virtual visits and link?
It's good. It's good. I think, I know everybody will ask that, well, how I can't just go back there for another follow-up or another, and I just say you don't have to. He does virtual visits, and he can tell you if there's an issue with your link. So
here's another question for us. Why do you need to lower the blood pressure meds, or perhaps no blood pressure meds at all, after Wolf Mini Maze? I've been on 3 blood pressure meds for 20 years. Love to be off them all. First, I read that really quickly. I thought it said love all of them, but it says love to be off them all. Very good question. About 10 years ago, we changed the post-op orders for patients who had the procedure to cut all blood pressure medicines in half immediately after the procedure. Why? Is because we saw with the usual pre-op blood pressure medicines that patients were on, their blood pressures were getting too low. So the blood pressure is commonly in much better control after the mini maze, sometimes with no blood pressure medicines when they were on before. Why? Well, there's been some research in this area, and it pretty much shows that the key is the left atrial appendage. When the left atrial appendage is closed, there are little receptors there that decrease the signals to the kidneys to try to hold on to more water and keep the blood pressure higher. So again, this is part of the autonomic nervous system. But the key is by closing the appendage, you change the system in your body, and the regulation lowers your blood pressure. Here's an interesting study that was done with a different way to close the appendage. One is the lariat, and another was a Watchman. Both those closures are done by electrophysiologists. The Watchman, in lay terms, is a cork stuck into the appendage to try to occlude it. Unfortunately, the cork is round and the appendage is not round. It doesn't electrically isolate the appendage either, but be that as it may, they looked at a cork inside the appendage versus closing the appendage, which electrically isolates it. In the patients that had the Watchman, their blood pressure did not get better. In the patients that had the lariat, their blood pressure did get better. In the mini-maze, we completely close it. It's isolated electrically, and the blood pressure goes down through these neurohormonal mechanisms. There are some hormones that are released by the appendage, but you release them from both right and left appendage. And we only deal with the left, but you still get this blood pressure response. Now here's a tough one. What does an unsatisfactory outcome look like? Well, I'll take a stab at that, and then I'll let Sandy tackle it as well. There are patients that come to us who've been out of rhythm for some time. I just talked to a patient in Juneau, Alaska, who had his mini-maze a few months ago. He had had 5 failed ablations. He came to Houston for the mini-maze, and now he's in rhythm. But it took a little while. He had to have a cardioversion a couple months after the procedure. He had to be on some medications for a while. The medications will be weaned. So in some patients, it's a process. It's not like I had my mini-maze yesterday, and if I have one more episode of AFib, it's a failure. That's not how it works, particularly if you've had a long history of AFib, continuous AFib, and or ablations. It can be after a month, a cardioversion is necessary. That's okay. That's not unusual. It may be, in some patients, after 6 months, there's still AFib or there's still a flutter. What we found is we can go back in with a catheter and touch up places that are outside the area of the mini-maze. And here's the really good news. That's been almost 100% successful. There's a patient that lives about an hour from Houston that the EP sent to me. He said, just close the appendage. This guy's been out of rhythm for 20 years. And I said, well, Joe, I talked to the patient and I told him we can close the appendage. There'll be a lower chance of success with the mini-maze because he's been out of rhythm for so long. And the patient said, Doc, why don't you go for it? You're going to be in there anyway. Just do the whole mini-maze. And I said, well, I think that's a good decision because I think we can even help you, even though your electrophysiologist thinks otherwise. So I did the complete mini-maze. A month later, he was out of rhythm. Did a cardioversion. Still out of rhythm. The electrophysiologist, to his credit, went back in, did a touch-up. He called me and said, you're not going to believe this, Randy. He's in perfect rhythm, and he's been in rhythm since. So even if the heart's been out of rhythm for a long time, it's a little bit of journey, but we can still get the heart back in rhythm. But an unsatisfactory is after we do all that and the heart's still out of rhythm, and that's extremely rare. But an unsatisfactory outcome is when we can't get the heart back in rhythm when that was our goal. In some patients, our main goal is just to close the appendage. I saw a patient today who's on a blood thinner, and he has a defibrillator. He got shocked, fell down, had a bleed in his head, had emergency neurosurgery because he fell down, hit his head, he was on a blood thinner, bled into his head. And our goal is to close the appendage. So a satisfactory outcome in him is not to get him back in rhythm, but get that appendage closed so he does not have to take blood thinner. So the goals are different in different people, but generally there are two goals. One, close the appendage to get off blood thinners. Two, get the heart back in rhythm. The third goal, the other goal, is get off the medications. Sandy, what say you?
I think people will contact me. Usually the first couple days they're in rhythm, and then on the third or fourth day they can have a little bit of flutter, and right away they're discouraged. They think that AFib is back, and I try to tell them that it's just flutter. People will still use their cardias even though they have the link, or they don't have the link at that point yet, but even afterwards, they use the cardia, and the cardia will say possible AFib, even if it's flutter. And I know I was on the phone with you all the time because I was terrified it was AFib, and you had to keep assuring me that it was a flutter. I just needed to hear it was a flutter and not AFib. I felt I could deal with the a flutter and not the AFib diagnosis. But yeah, I do get that a lot where, they just think that it's a fail. And I mean, like I tell people, I know the end result of this. We just have to get you there. It is a process.
That's an excellent answer. We got time for a few more questions. If you're on your phone, go to 37607, 37607. Text DEBAKEY and ask your question or give us your comment. Or if you're on your computer, go to pollev.com, enter DEBAKEY, and respond, and you can ask a question. Mr. Producer, Obed, could you go back to my slideshow, please? This is interesting. This is pretty hot off the press. July 30th, 2021. Could zapping the spine help prevent AFib in high-risk CABG patients? So these are patients, well, first, as an intro, AFib after heart surgery is very common. Generally, 35 to 50% of patients who have a bypass surgery or aortic valve or mitral valve will have AFib right after the procedure, even though they've never had AFib before. This was a study that suggested if you stimulated the spine, you could decrease the AFib. Now, what's that got to do with destroying the muscle? Nothing. It has to do with what we've been talking about. AFib is a nerve problem, not a muscle problem. So it makes sense that if you zap the spine, spinal stimulation, after bypass surgery, when the patient has AFib, it decreased the amount of AFib. So, again, here are two other little bits of information. I talked to a patient today who had a procedure about 6 months ago. She's up in your neck of the woods, Sandy. I think you know her, Sue. And she said that she had terrible motion sickness. She's had it her whole life. It's gone. Motion sickness is a nerve problem. And after the mini-maze, she said it's totally gone. She can go out on a boat now and she doesn't get sick. It's amazing. Yeah. It's a nerve problem. Here's another one. This is a rancher in Kentucky. We call them farms in Kentucky. You call them ranches in Houston. He keeps about 450 head of cattle. He takes care of most of them by himself. He had AFib continuously for 2.5 years, changed his insurance so he could travel to Houston, had the mini-maze. Back in rhythm, off all meds, doing great. Calls me up a year later and goes, "Doc, I really want to thank you." And I said, "Well, I'm just happy you're back in rhythm." He goes, No, you don't understand." He said, "I have Raynaud's. At least I used to have Raynaud's. And when I'd go out and tend to the cattle, even if it was 50 degrees or lower outside, all my fingers would turn white." He said, "Since the mini-maze, it's gone." Now you can't fake that. He's had it all his life. He's 55 years old, and now all of a sudden it's gone. So there's a lot going on with the autonomic nervous system. Some of it we don't know, but what we do know is if you can interrupt these nerves on the outside of the heart, it can treat AFib. Let's try to work in a couple more questions. I spoke to you last Friday, How soon can I come to see you? I'm ready to get this fixed. I'm ready to get off blood thinners and meds. I'm ready to get rid of it. Okay, well, we can help you out. We got a little bit behind because of COVID, but we're back up and running full speed, doing about 4 or 5 mini mazes a week now from patients all over the country. So if you're interested, again, you can call Kimberly, my nurse, at 713-441-9342, 713-441-9342, or go to wolfminimaze.com. Or talk to Sandy. And by the way, Sandy, we don't ask people to give out their phone number. In fact, we discourage it. But is there an email that you'd like to share with people?
Sure. If somebody wants to email me, that's fine. So Sandy Schrameyer, so SSCHRAMEYER@gmail.com.
Say that again, please.
S as in Sam, so SS, 2 S's, CHRAMEYER@gmail.com.
I guess another way would be to go on Facebook.
Yeah.
Go to Wolf Mini Maze.
Just Wolf Mini Maze, type it in.
But it's a private site to explain to people how they can get on.
All you need to do at the top of your Facebook page, just type in Wolf Mini Maze, and then just ask to join, and I will accept you. It is a private group. A lot of people do talk about, their health issues, and so we do try to keep it a private group. But just type in Wolf Mini Maze.
So go to Facebook, right?
Mm-hmm. And at the very top, in the blue bar, just type in Wolf Mini Maze, all one word.
And then what do you do? Ask to join?
Yeah, it'll come up and it'll just say ask to join. You just hit join.
Okay. And what's the time from asking to getting in? Is it a day or two?
I'm on the Facebook all the time, so it's pretty rapid.
Okay. All right. Now there was another question, Mr. Producer, you had up there. I think I remember it, or you can put it back up. But I think it said, what if you're in permanent AFib? Again, we can't help everybody, but we can help a lot of people. Oh, thank you. Would someone who has permanent AFib possibly benefit from the mini maze? Absolutely. For one reason, if you're tired of taking blood thinners, close the appendage and you can get off blood thinners. Keep this in mind. If you take Eliquis or Xarelto or Pradaxa or whatever the pill you take, you are decreasing your risk of a stroke by 60%. It's okay, but it's not great. If the appendage is closed, you decrease your risk of a AFib stroke by 97%. So you go from 60% reduction to 97% reduction, and you don't have to take blood thinners anymore. So that's one advantage. So in some patients, we say, maybe we can't get you out of AFib, but we can get you off blood thinners. The second opportunity is if the left atrium is not too extremely large on an echo where they just rub the gel on your chest, and I look at that, if the left atrium is not too large, then there's still a good chance we can get you back in rhythm, even if you've been out of rhythm for a long time. So the answer is yes, but it's personalized, and I would recommend a one-on-one with me, with a virtual visit, and we talk about it and we decide. There's no obligation to that, and sometimes it's thumbs up and sometimes it's thumbs down, but it's almost never thumbs down for getting you off a blood thinner. Would you agree with that?
I do. And most insurances cover your procedure. There's a handful that don't, but I know Medicare does for sure.
The best insurance is straight Medicare. And by the way, we're now in the season of re-upping for your insurance. So I do have a comment on that because I get asked this all the time. What's the best insurance to have a mini maze in Houston? It's Medicare, hands down. But it's not some goofy Medicare, it's just straight Medicare. And then you get a supplemental. See, Medicare covers your hospitalization and 80% of the other costs. The supplemental covers the other 20%. United's been very good. Blue Cross has been good. There are a couple that give you a really good price, but you can't go anywhere.
The Advantage plans, you have to be really careful with the Advantage plans because they don't allow you to travel out of state. And that's the big issue.
So if you're re-upping for Medicare or even any other insurance, you have to ask, I want a policy where I can go out of state. And if they say, well, that's going to be $30 more a month, that's nothing.
You get what you pay for.
I mean, but that's a deal. If it allows you to travel, and who knows, maybe you'll need something else. Maybe there'll be a new procedure for hip replacements that are only available in Wisconsin. If you have straight Medicare and you have the policy that allows you to travel, you can go there and have it done. I mean, as far as private insurances, most of them cover it, but again, it's policy specific. So when you're re-upping, which I think is now October, ask the questions. And if you can't get a good answer, go to an insurance broker and ask them.
One who sells all different insurances, not just one.
Right, who doesn't just sell one. Because they're going to sell you one and say, hey, we're going to save you $7.50 a month. Wow. But if you want to go out of state for something, it'll cost you $100,000 more. I mean, come on, it's not a good deal. Sandy, we're getting close to the top of the hour. I want to thank you personally for going through this journey and then saying, I want to help other people, and taking the time and effort to give your expertise and to offer help to people who are going through this journey. And any final comments from you about this whole business?
No, just that I do this because, like I said, you don't have to live this way. I was miserable for 3 years, and I mean, I feel better now than I felt 20 years ago, and I just want everybody to be in normal sinus rhythm, and I will do anything I can to help anybody reach that.
I'm impressed. A lot of AFib patients who do their homework know more about AFib than a lot of physicians do. Would you agree with that?
Well, I'll tell you, being a nurse, I didn't know much about AFib. I touched on it in nursing school, and then I really had to go back to my books and learn. And now I'm pretty versed on it. But there's a lot of learning to do. But you're right.
I want to thank Tyree, Obed, and of course our fearless leader, Alan Lumsden, who started these DEBAKEY CV lives for you all, for the people out there in the audience who have questions. Tyree, this will be posted almost immediately, so you can go back and look at it anytime on DEBAKEY. It will be on DEBAKEY CV Live. DEBAKEY CV Live. Sandy, thank you very much for joining us. Thank you for all you have done and continue to do. And for all of you that listened, we'll be back again in a month, first Tuesday of the month, 5 p.m. Central Time. Don't forget that, Central Time. Until then, stay safe and be AFib free. Thank you very much.
Bye.